Okay. Thank you for your kind introduction. And then congratulations on your first International Ocular Oncology Day in Essen. So I'll try to cover the most of the portion, but may not be good enough for the 15 minutes. So therefore, if you have any other question, I put my email address there. So please send me an email for your question. So this is my conflict interest. So move on. Just refresh your memory. Uveal melanoma is most common primary eye cancer in adult. However, compared to skin melanoma, it is much less frequent. Uveal melanoma harbors a driver mutation in G-alpha-Q signaling pathway, especially the majority patient has GNA11 or GNAQ mutation, which promotes the progression of disease. So secondary mutation such as BAP1, SF3B1, EIF1AX determine the aggressiveness of uveal melanoma. For example, BAP1 mutation, as Martin said, cause the early development of metastasis. In contrast, SF3B1 mutation tend to develop metastasis a little bit later, and sometimes develop metastasis in non-hepatic site. EIF1A3 usually is a good prognostic factor. Usually tumor does not metastasize. So up to 50% of patients subsequent develop metastasis. Interestingly, most of the metastasis develop in the liver. So this is a current consensus in the treatment of metastatic uveal melanoma, especially in the United States. As of today, there's no FDA-approved medication. NCCN guidelines are not so helpful because they suggest go to the clinical trials, or then the liver-direct therapy or systemic therapy have to be discussed. Then if you go to different institutions, they offer the different treatments, so therefore patient is kind of confused. There's no standard care established among the experts. So unfortunately, checkpoint inhibitor, which is work very well for skin melanoma metastasis, doesn't work for uveal melanoma metastasis. And the MEK inhibitor has been tried with very disappointing results. So most important thing is most of the medical oncologists in community may not understand the difference between skin melanoma and eye melanoma, and offer the same treatment as skin melanoma. That is not going to work. So that's a major confusion. Then what type of treatment is currently available, especially in the United States or Europe? There are three types of treatment: liver-directed therapy, targeted therapy, immunotherapy. As long as time allows, I want to explain this approach. Liver-directed treatment, majority of patients develop liver metastasis and then die of liver failure. So therefore, approaching to the liver metastasis is very important. So the hepatic metastases tend to have a blood supply from hepatic artery. So therefore, we can put the catheter from the groin, go to the hepatic artery, inject many medicine, and or sometimes close the vessel artery. In contrast, a normal liver has a dual supply from both the vein and hepatic artery. So therefore, liver cancer can be killed by the hepatic artery approach, but a normal liver can be preserved. So depending on what you do, there are so many different approaches, and then which treatment should be given is based on patient's size of tumor, number of tumor, location of tumor. So we need an interventional radiology group to work together. So now we developed the immunoembolization using GM-CSF, and then followed by the embolization of the hepatic artery. If you use ETM90 radio microsphere beads, we call it radio embolization. Chemoembolization with BCNU has been done for the relatively large tumor. And then also we can use DevDox, drug-eluting beads with doxorubicin or taken if patient tumor has a large and then well-demarcated. So in Europe, fordomastine has been given to the hepatic artery as an infusion. There's a new technology by using the device for the filtration of melphalan based on the subcutaneous approach, that's a PHP. Surgical approach is IHP. These are very aggressive approach with a higher response rate. Surgical resection is still offered to the small number of patients who has one or two liver tumor. However, due to the invasiveness or comorbidity in the United States, especially this approach has been almost replaced by the focused radiation, such as stereotactic radiosurgery or fractionated radiation. And microwave ablation has been done to cure the one oligometastasis. So obviously, liver target treatment has a little bit better overall survival compared to the other approach based on meta-analysis. Lantara, report 2,494 cases. Median survival is 1.07 years. And the isolated hepatic perfusion is 1.34 years, immunoembolism 1.63 years, surgery is 1.43 years, and then longer than other approach such as chemotherapy. So International Rare Cancer Initiative also report 912 cases who participated in clinical trial. As you see, liver-directed treatment is 14.6 months, and then much longer approach. Our institution shows the same similar tendency. We have 730 patients. We divided into 3 cohorts based on the years that they treat. And cohort 1, 70% patients receive systemic therapy, mainly DTIC-based chemotherapy. Cohort 2 and 3 has 98% of patients receive some type of liver treatment, either alone or with systemic therapy. Compared to cohort 1, cohort 2, or cohort 3 show the obvious prolongation of survival. And then somebody may say this is a lead time bias, but the same tendency is obtained for the time from the initial liver treatment, initial eye treatment to hepatic metastasis. Die. So therefore, lead time bias is not only a factor. Okay. Yeah. So this is a slide I borrowed from Dr. Ziga, who presented the result of the PHP at ASCO last year. So basically, this is PHP procedure, insert double valve catheter into the IVC to separate liver circulation from systemic circulation, and then high dose melphalan was given to the hepatic artery. And then these circulate, remove the blood, go to the device to remove the melphalan, and then after that, blood will return to the systemic circulation. So he reported that compared to best alternative care, this PHP approach improved the overall response rate, 32.9% compared to 30.8%. Progression-free survival was nearly tripled for the 9.03 months compared to 3.06 months. They didn't show the overall survival data that we need to wait. So this is well tolerable according to them, but still patients have to go to ICU. So therefore, this has to be done in a very experienced center. So in terms of target therapy, there's many targets. So this G protein mutation, alpha subunit mutation submits the stimulation signal to the downstream. This is the MAP kinase pathway. This is the YAP pathway. This is the PI3 kinase pathway. Each portion, some medication is developed and then tried to use. So most interesting approach is like a PKC inhibitor here, and then combining with MEK inhibitor. Also, FAK inhibitor has been tried combined with MEK inhibitor. So this is clinical trial .gov information for each target mutation has been or attacked by a combination of the multiple different medication, BAP1 is here, SSB1 here. But I want to just focus on this PKC inhibitor approach. So this shows some interesting regulation of the tumor. So this is data from the ΥΓΕΙΑ using their compound IDE196. This is a PKC inhibitor. Combining data with Novartis clinical data, they show the very good shrinkage of tumor. Roughly 61% of the patients show some type of regression. And then in 20% patient has a very good response, like so-called partial response. So they try to improve this by combining other medicine. In this case, IDE196 is combined with imatinib. This is a MEK inhibitor. As you see, this is very preliminary data, but still a little bit higher regression rate. And of course, combination is usually increased toxicity, like diarrhea, nausea, vomiting, and so therefore, they are also exploring a different type of approach. So this is an approach, another approach, combining IDE196 plus c-MET inhibitor crizotinib. They discovered that c-MET signaling from HGF may cause resistance to ID196 protein inhibitor. So therefore, by combining crizotinib c-MET inhibitor with ID196, just reverse the resistance mechanism, also suppress the signaling from PI3 kinase pathway. This is also ongoing treatment. It is a little bit better tolerated. So therefore, this might be an interesting combination for the increase of the efficacy. So I will just briefly cover immunotherapy. So generally speaking, as of today, immunotherapy it doesn't work well, especially for traditional immunotherapy. There are many reasons. Uveal melanoma is one of the least tumor mutation burden. So therefore, anti-PD-1 therapy response is a single digit compared to the skin melanoma here. So this liver metastasis, uveal melanoma does not express PD-L1, and the liver is also immunosuppressive microenvironment. So therefore, this is a very difficult target to attack. So as a result, immune checkpoint blockade that is successful for the skin melanoma is not working well for the eye melanoma. Ipi-nivo combination treatment, usually 40 to 50% response rate in skin melanoma, now 10 to 18% response rate is toxicity is safe. So therefore, the current approach is bringing some immune cell to the tumor site and either adaptive T-cell therapy, TIL therapy, or this is very important, interesting molecule. So I'm just going to focus on this immunoglobulin IMCGB100 to bring an immune cell to the tumor sites to increase the inflammation. So the other approach is combining the anti-PD-1 antibody with another immune checkpoint blockade like LAG3. So this is ongoing and then interesting approach. So this is a clinical trial approach obtained from the clinicaltrial.gov. I will just focus on this phase 3 trial of the IMCGB100 because this medicine may be approved. So this compound is very interesting. One end of the compound is T-cell receptor recognizing GP100 peptide molecule on the surface of MSC class 1 HLA-A2. The other end is anti-CD3 antibody, which bring a T cell into tumor site. So by combining this, we call this immune magnet. T cell go to the tumor cell to kill it. So interestingly, expression of the GP100 is more clear or more strong in the uveal melanoma compared to skin melanoma. So as a result, after infusion of this IMCGB100, now named is tebentafusp, we see a strong, significant drop in lymphocyte in the circulation. Then this biopsy specimen before the treatment is an immune cold tumor. It became immune hot tumor. This PD-1 expression, PD-L1 expression, and CD8 infiltration is seen. So one of the major toxicities is skin rash. Since GP100 molecule is also expressed in skin melanocyte, patient develops significant erythema, swelling of the face or skin, and that is usually short-lived. After 1 week, most patients recover. If you give multiple weekly treatments, patient develop the loss of pigment in the hair. So there is some data that this degree of the skin reaction correlated to the clinical response. So this is a phase 3 study, so-called the IMCGB100-202 study. Patient is randomized into a 2-to-1 ratio, either tebentafusp IMCGB100 or investigator choice. And patient should have HLA-A*02:01 and then no prior systemic therapy or liver-directed treatment. So primary endpoint is overall survival. Secondary endpoint is response rate and progression-free survival. So this is kind of very clear data. Tebentafusp has better overall survival compared to investigator choice. Median survival of tebentafusp is 21.7 months compared to investigator choice of 16 months. So based on the primary endpoint achievement, we expect that the United States government would approve this medicine sometimes in the future. So this is a summary of my discussion. The majority of just uveal melanoma patients died of progression of disease from metastasis, liver metastasis. Therefore, liver-directed treatment should be considered as frontline treatment to possibly prolong their survival. So there are multiple new medication in clinical trial targeting driver mutation of uveal melanoma, especially GLP-1 signaling pathway blockade is interesting. PKC inhibitor shows some clinical response, so therefore expansion of this clinical trial is expected. So in terms of immunotherapy, bringing T cell to the immune-cold metastatic uveal melanoma is critically important. In this regard, melanomas targeting T cell receptor anti-CD3 fusion protein, IMCGP100, show the very promising survival benefit over investigator-selected standard care, and then will become the key treatment for metastatic uveal melanoma with HLA-A*02:01. So more importantly, development of the multidisciplinary treatment team is essential because medical oncology alone cannot treat the liver metastasis. We need a collaboration with the interventional radiology. So therefore, develop the personalized approach. We need a team approach. Hopefully, we can develop such kind of team in many places in the world. Thank you for the invitation. I want to just show one more slide. This is a new approach, international collaboration of the uveal melanoma patient registry. This is started from the academic center under collaboration in the International Rare Cancer Initiative. And then UK group is involved, and also United States, Richard Carvajal, and then Olof is a key member of this kind of approach to increase the registration of the database of the uveal patient. So in collaboration with that patient center, the group like Melanoma Research Foundation, Sato, developed the patient-reported uveal melanoma registry system. So they are working together to increase the number of patients or accuracy data for the international collaboration. So I hope that the group from my colleague from the Greek is joining this approach. Thank you very much.
I hope so.